Well, welcome everyone. We're happy to have a very, very inspiring speaker to present for the next hour on integration of artificial intelligence and machine learning in kidney health. And this is Dr. Visit Chingpasaporn, and he is a professor of medicine in the Division of Nephrology and Hypertension at the Mayo Clinic in Minnesota. He presented the luncheon session today, which was absolutely outstanding, so I know you're in store for a wonderful session today.
All right.
Welcome.
Thank you so much, Dr. Russell Wilbicott. Thank you. All right, I'm going to get started, and I'm glad that everyone, here interested and also motivated to learn about, AI and, kidney health together. So this is my disclosure. So basically, AI tools that are shown example, not my endorsement. And please follow everyone institutional AI policy. And slides are available they're online to download. So just relax and enjoy. So first of all, we're going to talk about why AI in nephrology, why now, and then we're going to go over to AI, machine learning, the foundation, and so that part going to be a little bit serious, and then followed by AI application in kidney care, real-world integration, and I'm going to go to the limitation and ethics as well. So with the today talk, you're going to be able to describe fundamental concept of AI and machine learning in kidney care and identify the AI applications in nephrology that we already been using, evaluate the benefits and limitations, and how to apply those responsibly and ethically to our clinical workflow. So my talks, and this slides, the references are from the ASN AI statement that we just published this year from ASN Steering Committee, and also from multi-collaborative team that published the roadmap for clinical integration for AI in kidney care. So first of all, I want to hear from you all that are you already currently using AI in your clinical the practice? If you don't mind, help voting. So are you using it for patient care? Are you not using it? Are you planning to start using it? All right. All right. Yes and no. All right, good. So this is good mix of using and not using, so we can learn together how to use them. So why AI in nephrology? As you know that we have a lot of patients with kidney diseases, and many of them have complex the diseases like glomerular disease, for example. And also our patients have a lot of comorbidities that we need to pay attention to. Many patients on dialysis, many patients waiting for the kidney transplant. So we really need to help using AI to help with the diagnosis and treatment to improve our patient care. And also this is a great timing because as we already know that electronic health record is already well developed, right? We have a lot of the data to process. We have very powerful the computer, the ability. So now is the right time. And the problem that we have now is not the lacking of data anymore. We have a lot of data. And you can see that the data are complex. As we seeing our patient, we have a lot of data. How to use them to help support and help make diagnosis and improve our care is the next step. And you can see that when we have nephrology consult, when patients come in to my clinic or I'm seeing patients in the hospital, we have at least the 6 major data systems to look through. And there are fragmentation of this data as well. Most of the time, we don't know baseline creatinine or like, the medical record that sometimes, is the correct and inaccurate, or the from outside record that, you need to integrate them. And now we have a lot of labs that we need to go through, and those vital signs and machine data. So altogether, these are challenging and hard for us human without AI to process all of them. So this is a timeline of AI in nephrology. You can see that trajectory of the AI in nephrology is clear from early prediction model that we have, and we're still using them. Like, for example, KFRE, kidney failure risk equation, that developed by Dr. Nav Tangri, our ASN AI steering committee champion. When I was a resident, and now towards that I'm a nephrologist, that we have the generative AI foundation model, multimodal, and reinforcement learning model, as well as precision medicine era. So when we talk about AI and machine learning, what is machine learning? It is the subset of AI that use algorithm to detect patterns. And deep learning is a subset of machine learning that use neural network. And now I think everyone already know about generative AI, which is the subset of deep learning model that can learn and can also generate the new context, right? So I'm going to go over quickly about machine learning. Machine learning, 3 types of machine learning that we should know: supervised learning, unsupervised learning, and reinforcement learning. Thinking about the supervised learning as a machine learning that learning from label example, and unsupervised learning is a machine learning that help identify hidden patterns that without labels. And reinforcement learning is becoming more popular and used in the ICU for optimize the fluid and medication treatment that use the iterative feedbacks and optimization technique. So again, supervised learning can divide into classification and regression. Think about classification machine learning as answering yes or no question. Is patient going to have AKI, yes or no? Is patient going to have kidney transplant failure or not? That is a classification. And regression, thinking about predict the continuous variables, how model going to predict hemoglobin the next month in our dialysis patient, how the blood pressure control going to be after we start the lisinopril, how proteinuria going to be after we start the new treatment. That is the regression. So supervised learning, machine learning model is the models that you see mostly in our electronic health record. And we see in, the prediction model, is the patient going to need dialysis? Is the patient going to be admitted to the hospital? That's the supervised learning. And when you want to create the machine learning models, these are process of them, starting by data collection, feature engineering, training and validation, performance evaluation, right? And after that, when you have the model, it's not only finished right there. You need to also think about clinical integration and also monitoring after the model deployment. And that is actually the hardest part. As you see, 99% of the models that develop and publish never been integrated. And that is the part that we need to work on. And this example of supervised machine learning model, for example, predict, again, like I showed you, acute kidney injury. Or CKD, is the patient going to have progression of CKD? That's the patient going to have mortality during on CRT. These are supervised learning. Also, you may see in the literature about those glomerular disease diagnosis using the machine learning to identify crescents, for example, from the kidney biopsy, or the quantify the IFTA, or those like fibrosis. Those also using supervised learning, and those supervised learning that can identify the imaging, those biopsy and the CT scan or pictures we call CNN or convolutional neural network. And you may see in those literature a lot. Now coming to unsupervised learning. Unsupervised learning, I like that a lot. The model trained in unlabeled data and to understand about the disease. Many of the time, we human, make classification, like for example, AKI as a pre-renal, intrinsic renal and post-renal, or we classify, the membranous nephropathy based on PLA2R, no PLA2R, or other things. But this type of machine learning unsupervised, we use the computer, use the machine to learn about our patients and grouping the patient into the group, distinct the subgroup by the machine. And in fact, without bias. And in fact, it can do that efficiently. This is our study that we published in JAMA Surgery 2022 that we use unsupervised machine learning to understand about the kidney transplant patients, the African American transplant patient in United States, and see how many subgroups do we have by the computer. And we successfully identified them, and we found that these patients have different outcomes and potentially help us to understand the differences of the patient, to identify the right the treatment and the protocol to help improve the outcome. I'll give you another example. This study also understands about phenotypes or using unsupervised machine learning to identify subgroup of patients who have kidney transplant rejection. Another the example is using unsupervised learning to understand about transplant glomerulopathy, which is chronic antibody-mediated rejection, right? So these are examples of the use case, and in the future, I'm thinking about even more the studies on those rare kidney disease to use unsupervised learning into those diseases so we can understand them better than we do know about them now. So now I'm going to go to foundation model or generative AI and imagine about the machine learning that not only learn but can also create the contents. So for example, large language model can generate text, right? And this slide showing the Gen AI ecosystem that we have nowadays, right? We have GPT, we have Copilot, we have Gemini or Claude, or we even have more of them. So understand them is important because they have different the advantages and disadvantages. For example, my secret, I use GPT in the clinical workflow, and I'm going to show you how I use Copilot to connect with my Microsoft ecosystem that help with my Outlook handling. I use Gemini to help with my Google the system like Gmail, or the help with the search engine optimization when I provide the education content online, so other people will be able to search and find my content. Or Claude that is very good at coding and also can do PowerPoint presentation efficiently as well. In addition to the knowing about those, the Gen AI and also prompting techniques important, okay? As you know that the output that we have when we ask the questions or we give the instruction, the the output depending on the input and instruction that you give. So the learning prompting engineer can help your work and your workflow efficiently. And once you get your prompt, this I showed earlier, which is like the add-on extension that you can save your prompt on your web browser. And I do that. I save my prompt for the past year and a half now, and I call it out to help me to do the different tasks quickly. And this is free. The one that I use is Promptster. They did not give me anything, but it's free, and I really liked it. Now I'm gonna go over into AI in applications in kidney care. As you know, it's ranged from AKI, CKD, transplantation, and renal pathology. I'm going to go over one by one quickly. So the problem that we're having now is not having the models. We already have models, but how to how to integrate them, the data quality and workflow alignments are the next step. So, for example, acute kidney injury, right? The diagnosis of acute kidney injury based on like creatinine change, urine output change. But when we diagnose AKI, it's kind of late. The patient already had significant acute kidney injury. So there are prediction models that help predict acute kidney injury 48 hours prior to the acute kidney injury occur in many settings. The problem that we're facing right now, and likely going to identify the solution, is that once you detect AKI, what is the next step? Because a lot of alerts that we got, when we pilot this AKI prediction model, and we got the alerts that, hey, Dr. Wu said this patient going to have AKI in the next 48 hours. Then I'm like, what to do, right? Many of the time, the physicians, when get those a lot of alerts, then that don't have what to do next into the workflow, become fatigue, that we call alert fatigue, that we working on in terms of the AKI. And in critical care, right now, we are in the era of what we call multimodal, the data that we trying to integrate all the patient, the data input together. And in addition to that, we also working on getting those data from like CRT, for example, ventilator, those machine data we call to integrate with overall clinical data to make the prediction become more accurate and personalized. And again, after we flag the risk, the next is like we need to understand what should we do for that patient to help the reduce fatigue alert fatigue. Now I'm gonna go to chronic kidney disease and what we already have in AI in nephrology nowadays. So what I learned from Dr. Tangri, who is the creator of the KFRE kidney failure risk equation, and now we have AI screening for chronic kidney disease. As you see, there are many vendors when you go to the pharmacy. That there's the urine dipstick that you can use, and then AI application telling you that based on this urine dipstick, how much urine albumin to creatinine ratio is. And also there are the AI models that help screening chronic kidney disease based on the retina, the screening. Most of us going to ophthalmology very often and look into the, our retina, the eye ground, and then there's a model that help like detect kidney disease from that. And that's already been developed. Next step is to integrate it. Prediction model, the clean risk model, is the chronic kidney disease, the progression model that developed once again by Dr. Tangri, been validated already, now is in the process of integration. And you may hear about Kidney Intel X, the model that use the biomarkers that developed by Mount Sinai group. That's also the showing promising the result. But the issue is those biomarkers, they are not commonly tested by all other the organizations or institutions. So workflow integration is the next step that we looking for, and stay tuned for the next year or two. I think it's going to happen. For dialysis, what do we have now? Okay, we already have anemia the control model. So the anemia control model already used, especially in Europe by the Fresenius Medical Care. They use the AI model to help the adjust erythropoietin stimulating agent in the patient who on dialysis. Also fluid management as well as the vascular access monitoring. So imagine that the intradiabetic hypertension, you can predict about like up to the 30 minutes, some studies up to an hour before patient become hypertensive when on dialysis. So we already have those. Next step would be what should we do once we integrate into our workflow. Are we going to stop pulling fluid? Are we going to give fluid back? That question is coming next. So this is the future of our dialysis. As you know, that smart biomaterials are emerging. We have great the biomaterials for filters that been developing new the development that coming. And there are ongoing the efforts to use AI machine learning model to understand about machine data and patient and control. Maybe in the future, it's very likely possible that that AI machine, the machine dialysis will adjust the blood flow rate and everything by itself based on the AI prediction. It's like we using the auto-driving car, basically. So now I'm going to go to the kidney transplant, all right? As you know, it's an exciting time for the kidney transplant. There was development of donor-derived cell-free DNA and those like gene expression profiling. And now we have AI RNA signature. We have xenotransplantation, right? And this multifaceted the innovations likely going to help with our kidney transplant the outcomes better. For example, xenotransplantation is an exciting time. The organ perfusions they're also improving when we get the kidney transplant shifting to us. And also the AI-assisted pathology interpretation as well. So based on Dr. Lupi from Paris Transplant Group, the development of the prediction model of allograft failure from in the past, we had the static risk model, now to the dynamic risk, the prediction, and iBox, which is the dynamic the risk prediction for allograft failure, already been validated, as you know, and now under FDA review. So stay tuned for that. So this is a summary of the machine learning models in kidney care that we have, and my personal opinion about readiness of the use and what to do as a next step as clinician and researcher. So biopsy as well, the digital pathology is emerging, and there are different techniques that help identify this lesion more precise in the kidney biopsy. So hopefully AI will help us with closing the gap for the rare kidney disease very soon. Digital twins, you may hear this term a lot. so we collecting the data, genetics, omics, and all data, and we are planning to develop the digital twins model to understand more about the patients. Anyone want your own twins? All right, I do. I want my twins. Anyhow, so let's think about this, that, for example, IgA nephropathy, we have so many new treatments nowadays that coming out from the market. And it's hard to tell what if you start this, the iptacopan, what if you start the, SGLT2 inhibitors, what if you do steroids, so what happens. So we want to understand more, and we don't want to just doing trial and errors. We want to develop the twin model so we understand more about like what if we start the treatment or combination of the treatment, will that help our patient better or not? So again, a lot of models that I show to you, the problem that we have is like implementation, like most of them developed and never been implemented. So what already been implemented and what I already use at my practice. Documentation already happened. So when I'm seeing patient in the clinic, now I'm already use ambient AI listening. And what happened is the AI, the listen to the conversation and generate note for us. And again, this is the conversation, voice turned to text. Text going to large language model. Large language model generate the note for us. And we, physicians and providers, need to review. I'm not saying just physician because now we expand to like, nutritionists, the nursing team to be able to use these ambient tools as well. So with this, it's our responsible to review and sign, okay? And I showed this at lunchtime as well, that the study showing that, some the people is saving time, some people not saving time. To me, it's not about saving time, it's about allocating time. So you have more time to talk to your patient, the improving care for your patient, doing something that the important for your patient, for patient education, rather than just being worried about, writing down your notes, right? This is example, all the information about patient being modified, so the pictures as well. So I go to the encounter, I click the record, and I ask the consent with the patient, and then that's the conversation starting. I need to emphasize about ethical use because in my practice, although there's only one patient who declined that don't want to be recorded, it's the patient right, okay? And I also encourage you to write down and look into the search engine internet about the lawsuit ambient AI, the California. You will see that it happened in some practice that started using it without consent or without letting the patient know. And that became the problem. It actually just started this year. So if you want to use, you need to make sure that you follow your institutional the policy. And then you have your note done, you can choose the style, and you review them, okay? Now I'm gonna move to pre-visit and documentation and billing. So pre-visit now, the ambient AI also expand. There are many vendors, okay, that have this the feature. So you can see that with the pre-chart, it improved my efficiency in pre-charting very well. I understand before patient coming to see me for the kidney stone that, okay, patient went to emergency department with the back pain, found to have kidney stone from the CT scan, went to see urology, had the lithotripsy and stent removed. And then you can get to understand about your patient and start conversation to get more information, right? And you can Also, the change to the timeline, and you can get this information as well. After visit, now AI also can help generate the patient instruction. From my experience, patients loved it because they don't need to write down. Now they have the to-do list for patients, basically. And also improve the diagnosis ICD coding as well. So I don't need to manually type, and I just click add on the ICD code that's relevant to my practice. And billing as well, AI now able to suggest the billing code for us that we can consider. How about order and plan? At Mayo Clinic, we now working on piloting what we call ambient ordering. So when I'm talking to the patient and I say, I want to start lisinopril 10 milligram, AI already, make the order for me to review. And also, like, when I'm gonna get lab next week, AI make the order for me to review and sign. Also, this is the slide that I have not shown, and it's very new. For example, now there are some vendors that give the recommendation as well. So, for example, this patient, they found to have metabolic alkalosis, elevated BNP, and anemia. Then this AI embed the recommendation, smart recommendation that you can click on and then follow the guideline recommendation. So this is amazing. So after the post follow-up, you can see that now I have the large language model that incorporate into electronic health record that help communicate the lab result with the patient. We at Mayo Clinic, we have enterprise contract with GPT and the Copilot. It's different per different institution. And you can see that my chat GPT is different from my personal, the chat GPT. So we do not put the public, do not use public AI for patient care at Mayo Clinic, and emphasize that we do not put the PHI data into the public GPT. And again, we have enterprise version for ChatGPT as well as the Copilot. And that helped me with the many tasks that in the past took me a lot of time. For example, prior authorization. Now I have the GPT, customized GPT that I put the instruction and also the knowledge base about prior authorization, how prior authorization letter should be. And this is successful to get patients to be able to use medications that they need. And in the past, I forgot to do that, or it took a lot of time, like a week or two, and making in the delay in the treatment. And you can see with the ethical and responsible use, making me more efficient. Imagine myself that, working really hard and burn out to be top the performer for Mayo Clinic. So I need to say that thank you, AI. So now I'm gonna go to in the hospital. The hospitalization, when we get the consult, sometimes it's hard to understand why they consulted us. It took me a lot of time to look through the chart. But now we have AI large language model that incorporate into the inpatient care, and you can put the kidney, and now you understand that, okay, patient presented with the AKI, found to have ANCA vasculitis, had the rituximab treatment, and this is making me be so efficient in providing care for inpatient consult. We just started to incorporate the patient update as well. When you start your day, you can click on the AI Insight, and you would understand, okay, for the past 24 hours, what happened overnight. So instead of navigate through the chart and look at the chart at the nurse note or progress note. Now we have AI that help update what happened for the past 24 hours. And with that, there are new agents that we starting to coordinate and integrate it in our kidney care. For example, for kidney transplant coordinator, they are so busy, and we appreciate our transplant coordinator so much. That like responding to the messages and the coordinate the care. So our goal is not to replace our transplant coordinator, but to use the AI agent to help, draft the reply, the sending the lab order to the patients to improve and reduce the burden, okay, the administrative burden. So, for example, the CKD agent, the idea that we hoping that will happen for us is to incorporate the AI agent that help, remind the patient that, okay, your visit are coming, don't forget to get these labs, and and this is the questionnaire and blood pressure record that we want you to fill out for us, or medication, when the medications almost run out, send the reminder so we can get medication refill. In fact, if you look into the search engine Google, you will see that Utah already have AI for automatically refill the medication for the patients. Okay, so and some of the medications also involving kidney care, such as SGLT2 inhibitors or ACE inhibitor. So now what you can do is you can create the customized GPT, and you put the different the instruction in. For example, this example that I use GPT, custom GPT that help screening medication that can cause the kidney disease, and help flag medication that can cause kidney problem or hypertension. And then I confirm that with myself, human oversight and open evidence. Because as you know, that performance of ChatGPT, the not smarter than us, nephrology provider. So we need to make sure that we improve the accuracy by having the knowledge base for the AI, as well as fine-tuning them, and human always in the loop. So what I do, I use open evidence, and as you know, open evidence available for us who have NPI, or sometimes we can also submit the request that we are involving in education, and then the open evidence will give you the access. And open evidence use the knowledge base that published in the PubMed, basically, and the knowledge update every 24 hours. So the output that you get may change over time. The papers that published yesterday or the day before may show up as a new evidence. So to say that it's not 100% accuracy, you always need to check the reference and the primary source to confirm that, okay? Some that cannot access open evidence, you may consider DocsGPT from Doximetry. It also can give you the references, and it's also used retrieval augmented generation as a knowledge base as well. So I will come back to the case scenario. This is real case scenario that patient came in and my GPT agent flagged that Brukinsa caused the high blood pressure. I asked open evidence, which can give me the references and primary source, and confirm that it can cause high blood pressure. And then I can tell the patient and tell the oncology as well that that's happening. Okay. Next is for example, I have rare kidney disease agent that instruction always thinking about rare disease and have knowledge base in the rare disease, and help me give that differential diagnosis of the rare disease. And that happened about a year ago, I helped and did my best for the patient. I always doing my best. But at that case, it's so complex that the patient saw the many providers for the past 6 months could not walk on the wheelchair. We disclosed that we use AI to help investigation as well, and we make diagnosis of IgG4 related disease from that case and successfully treat the patient. And now patient have best quality of life and with smile with the family. So using AI responsibly and ethically can really help me as the clinical provider. Now I'm going to show you what else that not GPT related. So our kidney stone prediction model, we already incorporate into our the kidney stone care. When the patient come to see us, the patient have the report of the urine supersaturation study. So now we know that how many % change of kidney, like calcium oxalate or uric acid stone. And also from the scan, you can see that from the software, the kidney stone, that uric acid turn red and calcium stone turn blue. So based on this, the software, we also understand, okay, this uric acid or calcium-based stone. We also now use AI for imaging. AI automatically detect kidney stone for us and quantitate the stone for us as well. So with that, when patient come in, just have the kidney, like CT scan, like an hour ago, we have all report and can give the patient diagnosis and treatment plan for kidney stone. You can see that report also show that it's AI assisted the report, and our radiologist then review and confirm. So total kidney volume for patients with polycystic kidney disease now quantified by AI as well. AI look at the polycystic kidney disease and quantify the size of total kidney volume. You can see that in electronic health record now, we have total kidney volume that calculated by AI, and then plotting the GFR curve for us. And now, when I see, I can understand that, okay, over time, should I start patient on tolvaptan therapy for polycystic kidney disease now or not to help slow the kidney disease progression? We also have AI EKG dashboard. As we know that when we see our patients have a lot of comorbidities, including cardiovascular. That's why we have like the CKM, the work group that, cardio, kidney, metabolic. And you can see that with the EKG now, the EKG identify the risk of low ejection fraction or silent atrial fibrillation. And this is a real case that I saw in the clinic, just that the patient come in for the annual visit. Patient is very active and, not even notice that he has lower the functional status when he walking outside. He just thinking that it's because of his aging. But when we had the EKG, and I'm like, hey, look like it's possible that you may need to see cardiology because of risk of atrial fibrillation and aortic stenosis. We got the echocardiogram done quickly. We identified the cause. Patient got treated early with the TAVR and then have great quality of life. So this has been shown in the Kidney 360 that with EKG AI really helping our kidney transplant population that can identify those patients that may develop the atrial fibrillation after kidney transplant that may result in the poor allograft outcome. So what next? The multi-model data is coming. So as you see that the kidney pathology or digital pathology is something that they're coming up, and also omics data as well. And this is the real the workflow that we have. In the past, when a patient had a kidney biopsy, they just the pathology report. And I need to call the pathologist and talk to pathologist, or sometime running to the pathology office and ask to look at the microscopy together. But now you can see that you click on the open digital pathology, the tab, and you can see the biopsy. You are with your fellows or trainees or your patients, and you can show. You see, you have this is glomerulus, that the filter of your kidney, that the mesangial area have some expansion, hypercellularity. I should not say hypercellularity with the patient, but there are the more cells that inflame than they are normally. And you can see that the staining that for DNA, DNA, JB9, also positive, which is the marker of fibrillary glomerulosclerosis. So then patient and trainees understand better and then participate in their care better. So we also have the genomics tab that you can click on, and then it's integrated and collected all genetics data that patients ever have, even in the research or clinical care. And last month, when the patient came to see me with some cysts in the kidneys, but not typical for polycystic kidney disease, I asked about family history. Patient not sure. I asked about have you ever had the genetic testing? Patient also not sure. And then, okay, let's take a look. And then I click on, and then, okay, you had the test done, genetic testing negative, so you don't have polycystic kidney disease. Patient relief. And then, oh yeah, I remember now I had the genetic testing, but I forgot. So moving forward, the responsible adoption, we need to think about what is the priority for us, to help reduce burden and also improve patient care. We need to augment, but don't replace us, okay? So we need to think about the bias as well, because many models that develop and that we use at our center, we look into okay, if the Arizona using model from the Minnesota Mayo Clinic, would it work as well or not? And we see the difference because patient populations are different. So we need to think about that. We need to think about patient privacy and make sure that we follow the institutional policy. And we need to make sure that the part that human is important, human is in the loop. I want to say that we're gonna de-skill somewhat, but we need to think about what is okay to de-skill and what are skills that we need to keep. Myself, I need to keep core reasoning. I need to be able to think what's going on with the patient. But think about the skill that I'm ready to de-skill. For example, when I was in Thailand, we did dialysis catheter and the central line without biopsy, or without ultrasound, okay? Or we look at we did the kidney biopsy. I remember the time that we walking around in the ward at that time in Thailand without ultrasound. So now that we use ultrasound and use AI, some skills that is improve the patient care, patient safety, I am ready to de-scale. But some skills that is important for my value, I'm not gonna de-scale. Now I'm gonna finish my talk on the patient side, because patient also important. Now we know that the patient can also access to the AI. And it's known, for example, GPT has GPT Health. Claude also has Claude Health as well. So you can, the patient can integrate their the AI into the electronic health record. And then we see that there are a lot of more questions coming, so we need to be ready to answer or provide care in the new era of AI. I'm not saying that the patient using AI is wrong. We need to forget that concept and initiate the conversation with the patient about AI. This is example of the case that the mother went to see many specialists in 2023 because the child not able to walk and has a lot of symptoms. Many specialties not able to make diagnosis. But the mom did not give up. Get all the information in and put into the AI, and AI suggested that that is the theta cord syndrome. It's a real case if you look into that. The mom, that's the power of mom. I love my mom. That not giving up. And then tell the surgeon agree, did the surgery. And if you look into how the child doing now, back to life. So I'm going to say that the information if you put a lot of information, then you get the great result or get great output. But of course, if you just give a little bit of information, you may not get good the output. But this is example. I'm going to give you another example that is kind of sad, but patient ended up safe, okay? So when we see our patients in the clinic, we always say, don't eat salt, okay? Salt is bad. And that's true. Limit salt, make sure that, not causing hypertension. This patient, saw us, and then, of course, limit salt. Patient, look into ChatGPT by himself, is a real case. And he asked, anything can, replace chloride because sodium chloride is bad. You can have bromide, okay? And the patient, without telling the doctor, bought the bromide, sodium bromide, which is available to sanitize the water, basically. And patient used sodium bromide for at least 3 months and developed the hallucination, acne, require hospitalization with the bromism. Okay? So this can turn to be bad as well if patient just, follow the AI blindly without talking to us. So what we should do, okay, there's advantages and disadvantages. When the patient, another day, one of the patients had the lab, and then I told the patient, I'm happy with the labs, the kidney doing well. Patient said, oh, that's what my ChatGPT say. I'm very happy. I'm like, okay, that's good. And I'm glad that you brought this conversation, and I showed that it can be good, it can be not. Please let me know, if you have any questions, because, when patients arrive with the AI output, you need to engage and don't dismiss, okay? But the patients also, if you just, blindly ask the AI, you're not gonna get the great output. So, the patients, you need to also confirm, with the providers. So thank you so much. All right. All right.
Thank you very much.
Yes.
Thank you very much, Visit. We have a question that came across the app, but I'll first ask the audience, do you have any follow-up questions for our speaker? Yes, Danny. And I'll repeat your question if you don't mind. If you don't...
Mine is just a comment.
Okay.
Okay. You overwhelmed me from the beginning. You said your name. I put the generation that had problems learning the Casio calculator.
Mm-hmm.
And my question is, you've got so many fantastic tools and things there. What kind of learning curve from people of my generation is going to take to be comfortable with that? How do you start?
I'll repeat the question. Yes, so many wonderful options have been presented. related to technology and AI and so forth. And generations that are more used to technology can maybe adapt more quickly. But if you have someone who's not as used to so much technology all at once, how do you get started? Where do you take the first steps?
Yes, I think you already get started, and that's why you're in this room today. So and I want to say that this is how we as an institution moving forward with AI, which is AI education. We have like updates about AI, like something like, for example, the inbox messages. We're not overwhelming with a lot of information like this, but let's say in our the lunch, the division meeting, we also have like 2 minutes, updates about this AI tools, how you use it, what is a new feature. And over time, you learn along the way. And even now, the colleague who is like my consultant that initially wanted to retire because we started to use AI, now love AI. So I would say that start by the learning, and then the just small the steps at the time, accumulating as a big the knowledge over time. And if I would suggest the Google and Claude and even OpenAI themselves have the free educational tools. A lot of Coursera also have them. ASN and NKF also have the AI the materials for the clinicians and healthcare professionals as well.
Thank you very much. That was a great answer. And it is something that we're all just taking, I think, small steps toward, and it's a lot. So I think the next few years are going to be quite interesting.
Right, but you already get started.
Yes, yes. We did have a question. Any other questions from the audience? Yes, go right ahead.
So we got to see a lot of the ways that your team is already using AI. What I didn't hear is your team using AI to detect early access to transplants? So like if the GFR is at or around 20, it automatically fires like a referral to transplant in any of that capacity or similar?
Wow,
Repeat the question?
Yes, the question is have our team already use like AI to detect like GFR 20 or below, or if there's some high risk for GFR decline, should we flag and send transplant referral? And that is super excellent idea. There are some works that have already been done. We have not implemented yet. As you see that there are some workflows, a lot of things that we prioritize. And that is also important, is on to-do list. We have not done it yet, but it has been done. The people that started the nephrology referral, the outpatient nephrology follow-up, or transplant referral, in some center, but not widely the use yet. I wish I have another 4 hours to show what we have, so I can show all the information, but that is really great point.
Wonderful question. Any other questions from the audience? Very good. I have a question that came across from the audience. You sort of alluded to this, but maybe expand a bit. Can we risk seeing faulty AI results similar to how we see false positives on lab work? So the hallucinations and the misinformation.
Yes. And also I'm gonna say from the patient's perspective, that what I've seen that patients asking me about this. So some patients, like I showed that have like the high labs, a lot of information, and then they started to ask more questions. But some making like AI can make hallucination. For example, I'm gonna give you example not about the labs, but the report is really common. One time, I put the AI radiology report, that difficult to understand, to AI in order to make the AI friendly, the patient friendly, and send to the patient. For example, like moderate atherosclerosis, it's then the interpret as just mild calcification, and that is not correct exactly. Or earlier, that I mentioned in another class that important is that sometimes those misinformation that carry on in the electronic health record and then just continue to be carry on, and that is not good. Like patient with hyperaldosteronism that call Conn syndrome, CONN, but the provider put as the Khan syndrome, KARN, and then it get carry, and the note that AI generated also use that incorrect information. I'm telling you that you can search on the internet to see there are reported of the new the disease that AI just made it up. Throwing in the internet, because once you made it through the information in public available, and it's been trained by AI, and it's going to continue to train on the wrong information. So that's why when you get those information, you need to look into the primary source.
Wonderful. It's 5:30. Let's give our speaker, Dr. Cheng Pasaporn, a round of applause for a great presentation. Thank you very much.
Thank you so much.